Dr. Shekhar Chakravarti to start his course. Dr. Mehta, please.
Yeah, thank you, sir. Dr. Shekhar Chakravarti is our esteemed speaker today for the last talk of this program, short course program in hematology. And he's a well-known diabetologist and clinician, and he's the chairman of the API chapter of West Bengal. He's also the member of the governing body of National API. He has large number of publications, has received so many awards, and the most prestigious award is the Banga Ratna, which is the highest civilian award given by the government of West Bengal. He's the recipient of this prestigious award too. Now I'll request Dr. Shekhar Chakravarti to kindly start his lecture.
Okay. Thank you, Dr. Tiwari, Dr. Mehta, and all the senior leaders and my friends, colleagues, delegates present over here, and ladies and gentlemen. At the very outset, I convey my sincere salute to all of you in the occasion of Doctor's Day today, 1st July, and I am privileged to deliver the lecture on the first day of July, which is called the Doctor's Day and observed throughout the country. So, idiopathic thrombocytopenic purpura, current practice is mine. You know that the ITP is no more called idiopathic because it is an immune disorder. So cause is known. So it is not an idiopathic but a immune thrombocytopenic purpura. To define any thrombocytopenia, it is the platelet count falling below 1 lakh, usually manifested with some bleeding in the skin, mucous membrane, or genitourinary tract, and this is defined as a thrombocytopenia. Clinical picture depends certainly upon the platelet count, some localized purpura, and it is the platelet count which ultimately governs the type of the clinical picture. If we see the classification of the thrombocytopenia, it is basically either a decreased platelet production or platelet destruction, or there is a pulling of platelets into the spleen. Decreased platelet production is due to the bone marrow failures like aplastic anemia, MDS, megaloblastic anemia, as some storage disorders. There might be hypoplasia of the megakaryocytes in the form of alcohol intake and viral infections and toxins. It could be an ineffective thrombopoiesis or Wiskell-Aldrich syndrome. Our main concern and discussion today, when there is an increased platelet destruction, which is mostly due to the immune thrombocytopenia. There is an entity which is called a non-immune thrombocytopenia as well. Immune thrombocytopenia is usually an idiopathic, might be called an idiopathic, where really you cannot define what is the cause of this, but the process is immunological. It is divided into acute and chronic. And another is secondary, where the cause is identified, like infections, pregnancy, lymphoproliferative disorders, post-transfusion, viral infections like B, C, collagen vascular disease. There are some important drugs like heparin, gold salts, digoxin, which can cause immune thrombocytopenia. There is a good list, a good number of the cases, diseases that lead to non-immune thrombocytopenia. It's not my purview of discussion today. And the third group is abnormal platelet pooling. This is due to the spleen disorders in congestive splenomegaly or infiltrative disorders, or there might be the massive blood transfusion. Now, when we define that, what are the definitions, we should think about the primary ITP, when there is no cause is not known. And the secondary ITP means there is some underlying causes like infections autoimmune disorders, lymphoproliferative disorders, and the drugs. If you see the number of the cases of the primary and the secondary, you'll find that more than 80% cases are primary, and there are 20 cases of secondary where it could be an collagen vascular disease, infections, even Helicobacter pylori infections, HIV, hepatitis C, all these are included in the 20% of secondary. Now, when we treat a patient of ITP, it is very important to know, and a clinician should know, how you can classify the ITP according to the time frame. So the first is acute ITP, which is basically newly diagnosed ITP when the duration is less than 3 months. Persistent ITP when it is 3 to 12 months. Chronic ITP when it is more than 12 months. And refractory ITP means when there is a failure of medical therapy, or even after the splenectomy, there is relapse. So we call it a refractory ITP. I'll touch upon all and every aspects of this and their management. Certainly, which I have mentioned in my early part of my talk, that the symptoms is related to the platelet count roughly. Not always it is following that. When the platelet count usually more than 50,000, then symptoms is usually nothing. When it is around 30 to 50,000, there might be excessive bruising with the minor traumas. 10 to 30%, 30,000 in the platelet counts, there might be a spontaneous petechiae or a bruising. And when there is a less than 10%, it is dangerous because there is a risk of internal bleeding, particularly there is intracranial bleed, which appears to be life-threatening. So therefore, these are the basics of the ITP management. Coming to the epidemiology of the ITP, you will find that the ITP worldwide, it around more than 2 lakhs people are affected. Incidence in adults is around 2.8 to 3.9 per lakh population. The ITPs are, I have mentioned, it is a chronic and an acute. 2/3 of the adults ITPs are likely to develop as a secondary. Mean age of the adults, where the acute ITP mostly of children, the chronic ITP is the adults, and it is between the 35 to 45 years. As the age increasing, the prevalence is increasing. ITP affecting the children and adult indifferently, as well as the sex discrimination. So this is what is the incidence of the ITP according to the age group. This cartoon very explicitly shows that as the age advances, the ITP, the prevalence of the ITP and the incidence of ITP is increasing. And also in the adult, usually the females are more affected than the males. So whereas in children, the prevalence of the male and the female are almost equal. Now, pediatric versus adult ITP, there is a transit. You'll see the significant bleeding and comorbidities and male-female ratios are different of the IDP, pediatric and adult. As well as increased manifestations, you will find that as the age advances, the fatal major non-fatal bleeds are more compared to the fatal bleed, but the overall the bleeding is more than the younger subjects. Now the ITP affect almost all ages and the sex. The prevalence of elderly is quite high. Prevalence by sex, I have already mentioned that in young, male and female is almost similar. In elderly, the more are affected, the females almost 3 times more than the males. In children, acute ITP is very common. It's a frequent cause of thrombocytopenia. The very unique part is that it is almost most of the cases, almost 80% cases resolve spontaneously within 3 to 6 months, and 2 to 30% of children diagnosed as a chronic ITP in the later part of life. If you see the demographic pattern over the period of time, this is one temporal progression of the ITPs into 1990 to 2005 has been projected. It has been shown that over the period of the time, as the age advances, it is more. So therefore, in females are more affected than the males. This is the Indian perspective survey, IWISH survey, where it has been shown that there are very important survey regarding the clinical symptoms and signs, where you find that most of the patients of the ITP are presenting with the fatigue, and good number of the patients, young patients, are having the menstrual bleed, as well as the anxiety, petechiae, and headaches and migraines. Whereas in the elderly patients, there is more of the depression as well as dizziness and prolonged bleeding from the cuts. So these are the different subsets of patients of the in Indian perspective. We also will discuss about the response criteria. When we start a therapy, we should know what is called the complete response, means when there is an achievement of the platelet count persistently more than 1 lakh in the absence of bleeding. We call it a response which has got an early response and initial response and durable response. Response means when the achievement of the platelet count is more than 30 lakhs, because between the 30,000 to 1 lakhs, and at least a doubling of the baseline figures in the absence of bleeding. Early response means if it occurs within 1 week. Initial response means when it occurs within 1 month. Durable responses means when it occurs within the 6 months. We call it a remission when there is a platelet count more than 1 lakh in 12 months. So these are the American Society of Hematology Guidelines 2019. There are some other terms like corticosteroid dependency, when we call it a continuous prednisolone more than 5 milligram per day is required, or a corticosteroid equivalent, or there is a frequent courses of the corticosteroid maintain the platelet count more than 30,000 to avoid the bleeding. Refractory ITP, I have already mentioned, when there is a failure to achieve the response or a relapse after splenectomy and requirement of the treatments to minimize the risk of clinically significant bleeding. Here is a chart which shows that acute and the chronic ITP, it is very, very important to understand that acute ITP is mostly present in children, like 2 to 6 years, where the chronic ITP is mostly in the adults, 20 to 40 years. Sex predilection equal in acute ITP is chronic. In females are almost 3 times affected than male. History of infection, particularly the preceding viral infection, is usually detected in acute ITP, but chronic ITP, no such, but underlying causes might there. Platelet count is usually less than 20,000 in acute ITP. In chronic ITP is usually 20 to 70,000. Bleeding onset is usually abrupt in acute ITP, but it's insidious in chronic ITP. Duration is usually 1 to 6 months, and most 90% cases remit spontaneously, whereas in chronic ITP, it lasts over months and years, and most of the time it needs therapy. Prognosis is very good in case of acute ITP, and chronic ITP, it is variable depending on the situation. Now, how we can diagnose an ITP? You should know that the diagnosis of ITP is basically an exclusion. There are the guidelines like in International Consensus Guideline 2010, American Society Hematology 2011, already mentioned that the less than 1 lakh per liter is the diagnosis for the ITP. But for assessing, we should have the physical examination, patient and family history, complete blood count, peripheral smear examination. This is the diagnostic approach. We should go for a basic evaluation of the patients. We should do some tests of potential utility. We should advise for sort of unproven benefits. So these are the usual tests, bone marrow examinations, sub-quantitative immunological levels, and tests for HIV, HCV, and H. pylori. When we look for a patient of the low platelets, we should take the history properly. Has the patient ever had a normal platelet count? What is temporal profile, travel history, transfusion history, any other disease? We should go for the physical examination like lymphadenopathy, splenomegaly, stigma of the bleeding joint bleed, skeletal skin necrosis. These are the laboratory tests like CBCs, examinations of the blood film, blood cultures, NA test, and direct globulin test. We may go for bone marrow aspiration, but which is not required most of the time. In case of acute ITP, sometimes mostly it is required to exclude the lymphoproliferative disorders. And there are other tests like coagulation profile and many other tests to be done. So this is usually a peripheral smear. When we get a thrombocytopenia, we should examine the peripheral smear. We should see whether there is a platelet clumping, it is a pseudo thrombocytopenia, or whether we are getting a true thrombocytopenia where we get giant platelets most of the time and some plus minus the WBC inclusions. And this true thrombocytopenia, we should for the cystocytes, we should for the blasts and nucleated RBCs, macrospherocytes, we should show lymphocytes and atypical lymphocytes, and isolated thrombocytopenia. This is the way we should approach for the diagnosis of the different etiologies of that. Pathophysiology, mostly you know that the mechanism is basically the peripheral destruction, is an epitope spreading. A decreased production might be some anti-megakaryotic activity. Cytotoxic T cell is leading to direct cytolytic activity of the platelets and some molecular mediated infections. So these are the destructions and the sequestration of the platelet their production and destructions is there, and also sequestration is there. So ITP pathogenesis, mostly there is an platelet destruction by the spleen, by the macrophages, and there is to some extent the impaired platelet productions as well. It is also the immunological in nature. So this is the basically balance between an increased platelet destruction and a decreased platelet production by the bone marrow. And so these are the balance ultimately leads to the manifestations. So mostly the decreased platelet production in the bone marrow are T cell mediated, whereas the increased platelet destruction is mostly the B cell mediated or antibody mediated. So this is the overview of a pathogenesis of ITP. So coming with this, the management, you see that in case of acute ITP, when there is a thrombocytopenia, but the platelet counts is more than 60,000, usually no therapy is required. When it is less in between 20 to 50,000 with a significant mucosal bleeds, we may interfere with the active management. Most of the time, the steroids are required with a high dose immunoglobulins. Platelet counts when there is less than 10,000 fail to respond to the steroids. Usually the therapy is steroids, high dose immunoglobulins, and platelet transfusion. If it fails, then we can opt for the splenectomy. So this is the section from the splenectomy which has been done, and which the cases fail to respond to splenectomy, there is a refractory thrombocytopenia. I'll come to this management. Regarding chronic ITP, it is basically a lifelong battle with the platelet deficiency. 80% of the adults and 20% of the children are having this. Incidence is highest among the females, and the basic management of the ITP, chronic ITP overview is that we should control the hemorrhagic symptoms and prevention of the hemorrhagic symptoms. We should improve the health-related quality of the life and inductions of remission. These are the different platelets profile. When the platelet count is more than 60, no treatment is required. Between 30 to 50, we may give the treatment, may not, where the usually prednisolone is given 1 to 1.5 milligram per kg per day for the patients having hemorrhage. When the platelet count is less than 30, prednisolone dose is higher. We can give immunoglobulin as well. When there is a life-threatening hemorrhage, treatment is emergent, that to be done by platelet transfusion, intravenous immunoglobulin, usually 1 gram per kg per day for 2 to 3 days, and methylprednisolone, usually 1 gram per day for 3 days. So these are the treatment goals for newly diagnosed adult patients. We should rapidly obtain a safe platelet count. Persistent and chronic ITP I have mentioned, refractory ITP I have mentioned. So this is the gradual manifestations. Usually we start with the observation, then in corticosteroids, IVIG, say other is TPO receptor agonist, rituximab and splenectomy, and immunosuppression and cytotoxic drugs. This is the current guidelines of the ITP management. First line therapy is usually corticosteroids and IVIG, and see the response. In case of adult, there might be splenectomy. Second line therapy is usually thrombopoietin receptor agonist. Rituximab might be danazol, dapsone, might be H. pylori eradication, azathioprine, cyclophosphamide, or mycophenolate mofetil. Third line management, usually the first and second line management, including TPR agonist or combination chemotherapy. I just highlight about the corticosteroid pros and cons. Corticosteroids, cost-effective treatment, usually responds within 1 week, and 3/4 of the patients respond most of the time. There's many side effects, you all know this, on the steroids. IVIG is effective in 80% of the patients, raises in platelet count very rapidly, but there are the side effects like headache and fever. Requires pre-medication, and responses may be transient. 1/3 of the patients fall below the acceptable level. Splenectomy responds most of the time, around 70% response. Low rate of late complications. There might be sustained remissions. It is rarely recommended in children because most of the acute ITPs are spontaneously remit, and risk of complications certainly is there. High cost, irreversible organ failure, and all patients should be prevented by vaccinations. Rituximab is usually the 6 to 12 months duration response. Steroid sparing effect is there, mostly mild to moderate adverse events. Few children achieve long-term responses, although rare adverse events may impair responses to vaccination. Long-term data of the safety are unavailable. This is the treatment of the refractory ITP, where immunosuppressive drugs like rituximab, mycophenolate mofetil, dapsone, azathioprine, cyclophosphamide are used. There might be adjunct agents like thrombopoietin receptor agonist, ramiprostine, and L-thrombopag, splenectomy, and immunoglobulins at the therapy. This is the study where the rituximab has been used, 375 milligram per meter square weekly for 4 doses, and the outcome was 54% response rate. Current challenges are there. There's problem with maintaining the platelet count over 30,000. So thrombopoietin receptor agonists are developed, and they are very, very effective. And actually the important issues is that in spite of the ITP, the thrombopoietin productions are not that high, because you know that the thrombopoietin is produced by the liver and acts on the megakaryocytes. So if we can supplement with the thrombopoietin, then we can encourage the megakaryocytes to produce more. This is the mechanism of action, how L-thromboprobe acts on these sorts of megakaryocytes. So clinical evidence, RAISE design has been shown that 50 milligram of L-thromboprobe with a standard of care is better than placebo. And there is a maintenance of the platelets over the 50% of cases with the L-thromboprobe therapy. So 79 patients has responded to treatment at least once for 6 months period, where the 28% in the placebo. This is the summary of the RAISE itself. I am not going to detail. Summary for the efficacy is one of the very efficacious product, and so that who grade 3-4 bleeding were infrequent, and all except 5% required dose adjustment. Safety, it is one of the safe drug. Hepatobiliary side effects and cataracts may occur, and majority of the patients is safe. This is the dose adjustments. Usually the 50 milligram to start with, you can reduce the dose as the platelet count is improving from 50,000 to 2 lakhs, 25 milligram, and gradually, and when there is a persistently more than 4 lakhs per platelets, you can omit the L-thromboprag. Romiflostin also is used for chronic ITP, and this study shows that there is a maintenance of the platelets with the romiflostin, and there is 38% durable response and 79% overall response with romiflostin. So these are the pros and cons, because pros is very good short-term safety and effective in both splenectomized and non-splenectomized patients. Long-term safety is not known, but it is cost-effective. So now, 1996 to 2003, the newly diagnosed patients will give the IVIG and steroids, then splenectomy, and in chronic cases, cytotoxic agents. And in 2015 onwards, you'll see after the splenectomy, when you can use the rituximab and L-thromboprag or sort of TPOR agonists, and also the cytotoxic drugs you can use. Now, in 2018, you'll find that the rituximab can be placed before the splenectomy. So if we find, I'll show you that the incidence of the splenectomy has reduced over a period of the time because of the invention of the rituximab and L-thromboprag for the treatment of the ITP. So these are the different infections. I'm not going to detail. So these are the options we have already mentioned, that these are the treatment goals for the ITP. Usually start with the steroid, then there is TPORA, then rituximab, then splenectomy, the cytotoxic agents. This is the usual flow in 2019-20 guidelines, and it holds today. There are the other drugs like mycophenolate mofetil are there. Prognosis, 80% of the children respond spontaneously. For the adults, there is a response, good number of the patients. This is the comparison of the different therapies: corticosteroids, IVIG, immunosuppressions, splenectomy, and this where how we'll get a approximate time to response and sustained rate of response. One important slide is that splenectomy has a decreasing rate of splenectomy over the period of the time. You'll find that it is decreasing, but splenectomy is a very good option, was at the time before the advent of TPR agonist, and as well as the rituximab. There are the new drugs in the expanding horizon. These are the newer drugs like efgartigimod, and these are the other drugs like lanalumab, as well as povetacicept, rilzabrutinib, and justilumab. The rilzabrutinib is oral and reversible therapy. They are basically the drugs which inhibit the B cell activation, and they act as well as in the macrophages. So these are the trial. LUNA-3 trial has been done with the rilzabrutinib, and it has been shown that the good number of the patients are responding to 400 milligram twice daily is the rilzabrutinib therapy, and the response is quite good. and initial platelet response is quite satisfactory. It has been found that those patients who are responding within the 2 weeks, they maintain the 65% of the patients are responding in the 2 weeks, and they maintain the platelet count more than 60% over the period of the time. Those patients who are having the platelet count is responding in 50 days, around 30%, they are maintaining the at a lower scale. This is the durable of the treatment is there. It is not only that over the period of 25 weeks, 1 year, the therapy with the rilzabrutinib is maintained. And this is some of the secondary endpoints are also achieved with these. So to conclude that rilzabrutinib is a rapid and durable platelet response, improves the quality of the life, and generally well tolerated and difficult to treat patients in ITP. Another drug is fostamatinib, and it is also a very important drug, which is basically a drug which is SYK inhibitions, and it causes the response, and highly refractory patients are responding to these drugs, and it has been shown in case of PROMISE trial. And this is the SYK inhibitor, is a FIT study, FIT1 and FIT2, and it has been published in 2018. Fostamatinib is a therapy, a line of therapy, it matters. It has been found that those patients have started early, they are showing a better response, and early means as a first line and second line therapy than those patients who are receiving fostamatinib as a fourth or fifth line therapy. Another is sovleplenib, is a drug which is also used, and it has been found that duration of the response is over the period of the time. And mezagitamab is a TAC 079 study where it has been shown that the patients are responding to the maximum therapy. There are the 3 doses, 100 milligram, 300 and 600 milligram. 600 milligram has showing the best response in the term of platelet response, complete platelet response, clinically meaningful platelet response, and hemostatic platelet response. So mezagitamab is also maintaining the 600 milligram. Another is lenalidomide, is a BAF inhibition, and it has been found this is basically a beta cell stimulator as a BAF receptor monoclonal antibody. And there are the trials like VHIT2 study and VHIT3 study. It has been shown that over the period of 24 months, there is significant improvement of the platelet count, particularly those who have got a refractory. These are the results, not yet are not published. This is the ASH update in 2024. So to conclude, my talk is that ITP is a diagnosis of exclusion. Backbone management of newly diagnosed ITP is still the steroids. Patient with the severe bleeding may require platelet transfusions, IVIG or IV methylprednisolone. Shared decision making is very, very important. It has been, I haven't shown the therapeutic guideline and the flow where the patients, clinician should share with the patients whether the patient is opting for this therapy or not. This is very, very important in the guideline. Ambiguity regarding the choice of second lighting treatment can be mitigated with the larger studies comparing splenectomy, rituximab, and thrombin agonists. Thrombopoietin agonist. Cost analysis evaluation of the newer medications is very important. Ideal sequencing trials available of FDA approved therapies, I have already mentioned, and there should be an exploration of the various combination therapies of the ITP. There are the still areas, some areas are still remain gray, where even the 10 to 15% of the chronic ITP are not responding to therapy and succumbing to death. So there is a more horizon to explore. So thank you very much for your patient hearing.
Thank you so much, Shekhar Chakraborty sir, for an excellent deliberation about the ITP. Definitely, ITP is the exclusion diagnosis. So first, we have to find out the cause of that. Thank you so much, sir. So sorry for joining late, sir. Actually, I have my class for 2 to 3, and unfortunately, we have this Tuesday class. So, but now I have joined. So, any questions in the chat box right now? Anybody want to ask something?
What is the comment of Dr. Mehta?
Yes, sir. Mehta sir just left because of some urgent work. He called me that he is going. Then I have to take the session right now. So, sir, like there is a IVIG and this steroids. So, should we keep continue if a patient having no symptoms? Because like sometimes I have seen a few patients of mine that they were the platelet were 5,000, 10,000. If we are giving something, then they will go high. But once we are stopping them, then they so there is no steroid sparing there, na? So in that condition, should we give continuously lifelong these steroids or what?
That is there is the some patients are there who cannot maintain the platelet count over 30,000, even up to the 5 milligrams. So there are some patients are the steroid dependent. You have to give at least 5 milligram of prednisolone per day. Unless you give this amount of prednisolone, the more than 30,000 platelet counts is not maintained. So these are the steroid dependence ITP. So, but the thing is that when even then, you say, for example, when you try to taper the platelet count, some patients' response is like this, that the platelet count is going down and it comes to less than 10,000. Now, when it comes, then you can call for other therapies as well. Now, you see, the important therapy is L-thrombopag, which is very, very available, though costly, but very, very good therapy where a combination of the steroid and L-thrombopag can be maintained over the period of the time. You also can give the patients with rituximab, and rituximab, if you give a patient on a pulse therapy, you'll find that the patient's platelet is being maintained. And even after the rituximab, you can continue with the steroid and L-thrombopag. And also, if the patient is, there is failure of the medical therapy in the form of, say, a steroid, immunoglobulin, and the L-thrombopag, then you can consider the cytotoxic therapy in the form of mycophenolate mofetil. My experience with the mycophenolate mofetil is that if we can continue with the 500 milligram mycophenolate mofetil twice daily, good number of the patients of ITP, they maintain their platelets more than 50,000 and over the period of the time. So mycophenolate mofetil in combination with azathioprine, you can continue 50 milligram daily or 50 milligram twice daily of azathioprine is good to maintain the platelet therapy. Even then, if there is no such response, then you can opt for splenectomy. And even after that, there is the refractory anemia, refractory thrombocytopenia, even after the splenectomy. In that cases, the newer drugs which are coming, these drugs has been studied for the refractory thrombocytopenia, and that can be used.
Sir, there is another question in the chat box by Dr. Neha Kumari, and she wants to ask the role of splenectomy in ITP.
Actually, this is very good question that now if you look into the pathophysiology, you will find that the platelets are actually is surrounded by the autoantibodies, and these autoantibodies make the platelets are very vulnerable to the spleen. So when these antibody covered platelets are entering into the spleen, then the macrophages which are present in the spleen, they engram the platelets, and that's why the thrombocytopenia happens. So it is also dependent, this is the antibody dependent platelet destruction. there might be a complement dependent platelet destruction as well. There might be complement opsonization of the platelets, and that leads to ultimately destruction in the platelets. So now when we do the splenectomy, what happens? These opsonized platelets by the, immunoglobulins, they are not being destroyed by the spleen. So the thrombocytopenia doesn't happen. But this splenectomy is not equal in the acute ITP and the chronic ITP. In the acute ITP, which is mostly for the children, which is 90% cases are spontaneous remission, the splenectomy is not required. But in chronic ITP, when there is a medical therapy fails, then the splenectomy is required. And this is the mechanism by which if we go for splenectomy, the platelet counts immediately goes up. And it is maintained over the period.
Yes, sir. So next question is effect of ITP in pregnancy.
Yes, the thing is that ITP in pregnancy is one of the serious issues. Then you see some of the cases, there might be in some cases of pregnancy, there might be ITP. And in that case, one important issue that it has been studied and it has been found that the 7% of the pregnancy cases are having the low platelet counts. By definition, if it is less than 1 lakh, we call it an ITP. But up to 60,000, nothing should be done because the patient is asymptomatic and this is a physiological response. But when the platelet counts below 50 and between 30 to 50, it is the best to use the steroid because steroid is safe in pregnancy. It can be used. But the L-thrombopag, I'm not very sure about its pregnancy, but mycophenolate mofetil should not be used in pregnancy, and other drugs, IVIG. So base drug is to use the steroid to maintain the platelet count more than 30,000. And when the platelet count goes below 10,000 and there is risk of bleeding, in that case, platelet transfusion is required. So therefore, in pregnancy, you have to be very judicious to use the drugs because most of the drugs which are used in non-pregnant state are contraindicated in pregnancy except steroids.
Dr. Satija wants to ask, sir, can we start L-thrombopag in acute ITP?
No, acute ITP by definition is occurring within 3 months. Means it resolves most of the time is 3 months. And acute ITP is occurring in the children, most of the time in the children, 2 to 6 years. And it has been found that it is resolved most of the time spontaneously. But if it happens that if the platelet count becomes very low, say for example less than 10,000, the platelet transfusion should be given. And in that case also the steroid is required. There is no study of the L-thrombopag. So far I know that no study of the L-thrombopag in children. So yes, there is a study in children where the 25 milligram is used. I forgot it. 25 milligram L-thrombopag is used in children, and it has been found that it has got an effective platelet rising characteristics, but very rarely, only 10% of the patient needs some sort of supplemental therapy like steroids and L-thrombopag.
And again, the next question from Dr. Satija, and he wants to ask how sensitive is giant platelets and the MPV in peripheral smear for diagnosing ITP?
It's a very good question, Dr. Sir. The thing is that most of the time, when you see the peripheral smear, you will find that the platelets number is less, but the platelet size is large. Normally, the platelets are very, very small, less than 1 micron. But when there is a large platelets, it is around 4 micron. It is almost half of the size of the RBC. So these are called the giant platelets. And these giant platelets indicates that there is a problem of ITP at the level of the megakaryocytes, because the megakaryocytes cannot produce the large number of the platelets, so that's why the giant platelets. So giant platelets and also some inclusions in the WBC shows that it is we are dealing with the ITP. Another important is the distribution width, platelet distribution width. When we find that when the platelet distribution width is high, then you will find that there is the variability of the size of the platelets. When there is a variability of the size of the platelets, as a small platelets, medium-sized platelets, giant platelets, there is a variability of the size, then the platelet distribution width is high. And that also indicates that there is a chance of ITP. So by these two, you can identify. And also the mean platelet volume. In mean platelet volume, as there is a giant platelets are there, mean platelet volume is also increased. So therefore, we'll find. So these three things in the peripheral smear, the giant platelets, the platelet distribution width, as well as the mean platelet volume, all are suggestive that the patient has got, we are dealing with a case of ITP.
Thank you so much, sir, for answering all the questions. Our residents are just having curiosity, and after your lecture, I think all questions answered. So, anybody want to ask more, or we can conclude today's talk? I think no one is there. So again, at the outset, I would like to thank on the behalf of our Dean ICP, Dr. Kamlesh Tiwari sir, and the course director, Dr. Sudhir Mehta sir, for giving your valuable time. And thank you to all the residents, all the participants who have joined us today on this 1st of July, the Doctors' Day. And I wish you everybody a happy Doctors' Day, sir. This is our last class of this series of ICP's hematology certificate course. Now we have completed the 20th class. Our residents will soon receive the your examination uh, information, and then you have to pass out. That will be an objective based 50 questions will be there, all hematology 20 classes which have been taken by the residents. So be prepared, all dear residents, about the examination. And thank you so much, Dr. Sekhar Chakravarti sir, for giving your valuable time. And we're looking forward to much more certificate course in the next future. Thank you so much, and happy Doctors' Day to once again to everybody. Thank you, sir.
Thank you. Thank you, Dr. Daria. Thank you.
Thank you, sir.